Hello again, everybody. We're going to talk here about the surgical management of gastroesophageal reflux disease. Now, I did a video in my internal medicine talks under the gastroenterology section where I talk about the medical management of reflux disease. And I go into quite a bit more detail about reflux disease and how we manage this typically on an outpatient basis. And that is the vast majority of reflux disease. As I'm sure you know, there are millions of people who have reflux disease, and only a small minority are going to go on to need a surgical management. We're going to kind of gloss over a little bit about the diagnostics here and really hone in on who needs surgery and when. So that will be the focus of our talk here. But if you want to learn more about reflux disease, go back to my internal medicine videos and watch that. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already donated. All right, so we'll just do a quick overview here. We'll talk about how these patients look. We'll talk a little bit about the medical management. When do we do surgery? We'll look a little bit into the technical aspects of these fundoplication procedures, the most common being the Nissen fundoplication. And then I'll briefly relate to you some of the complications that can arise from this. So GERD is the number one identifiable cause of epigastric pain. And GERD has a tendency to ascend. So patterns of pain are really important. A crushing pain in the chest is likely to be an MI. A tearing pain in the chest is likely to be an aortic dissection. A stabbing, gnawing pain is likely to be an ulcer. Okay, so when we're talking about a burning, ascending pain, that is likely to be reflux. Because remember what happens with reflux. The stomach contents escape through the lower esophageal sphincter and they rise up the esophagus. And a lot of people, this happens. If you've ever tried burping and you get a little bit of reflux, that's exactly what it's like, except these people, it just happens. Now, reflux is thought to be due to excessive relaxation of the lower esophageal sphincter. As you get older, sphincters tend to get a little weaker. You probably know some older people who have told you they have some embarrassing moments when they get up. That's just because sphincters get weaker as we get older, and so this tends to increase in incidence with age. Often, this is perceived as substernal pain, although it does originate in the epigastric area. It radiates along the track of the esophagus. This pain is usually described as burning or as heartburn. Other symptoms, this can cause a sore throat if this gets into the, if this gets aspirated a little bit. It can certainly cause some hoarseness. It can cause sore throat in the oropharynx. This can also cause wheezing if you get a little bit of aspiration. This can irritate patients who have asthma, so it can trigger asthmatic attacks. These patients may have a metallic-like taste in their mouth. Rarely vomiting may be present, but naturally, if you're refluxing, that can come out your mouth. And then we always need to be vigilant for alarm symptoms, and we'll go over what those are, but anything that makes you suspect the possibility of a cancer, anything where you suspect the possibility of a bleed, those are alarm symptoms, and that cues us off to maybe we need to do an endoscopy. So the exam is going to expect you to know the difference between reflux pain and other types of quote-unquote chest pain. If you don't know, if it's not obvious, go ahead and get your cardiac enzymes, your EKG, and your chest x-ray and all that workup. You can't go wrong. Somebody with reflux disease is not going to die on the table of reflux disease. But if they're having a heart attack, they could die from the heart attack while they're in your ER. So if there's any question, please do a cardiac workup. Now, obesity increases the risk of reflux disease just because it increases the intra-abdominal pressure. So naturally, that's going to push contents out or favor the pushing of contents out through the esophagus. We talked about the symptoms. The diagnosis, assuming you've ruled out cardiac causes, if the diagnosis is questionable, then the test that you would do would be pH monitoring, although I would say in practice, we basically never do that. If the patient does have a classic presentation, which they almost always do, then the diagnosis is made clinically and you will proceed to medical treatment, provided they have no alarm symptoms. So the treatment, if patients have alarm symptoms, and one of the big ones here that commonly gets forgotten is long-standing GERD. So if they're coming in and they say, "Doc, I've been dealing with this for 8 years, I'm finally coming in and getting help," they're going to be sent off for an EGD. Whereas if they came in and they said, "Yeah, this started 6 months ago," then no. So once you have formally diagnosed the patient with reflux disease, then medical treatment should be initiated. We never go straight to surgery, and that's a pretty common theme in a lot of cases. So always know your alarm symptoms. So things that make us think possibly cancer. So weight loss, that's unintentional weight loss. Signs of bleeding like anemia or heme-positive stools. So when you got a patient coming in with reflux disease or suspected reflux disease or maybe suspected ulcer, any kind of GI issue, it doesn't hurt to get a stool guaiac test, because whether the patient is bleeding is certainly going to impact your differential and your management. So do not hesitate to get a stool guaiac. You can do it in the clinic. Dysphagia, odynophagia, and then, like I said, symptoms more than 5 years. Now, to diagnose these patients, if they are over 50 years old and they're coming in with symptoms for the first time, you're going to get an upper endoscopy. That is recommended. If they are under 50 years old, you ask yourself if there are alarm signs. If there are, you go to upper endoscopy. If they've got a clear picture of reflux disease, they don't have alarm signs, so you got a 28-year-old coming in with 8 months of reflux symptoms, you're not going to bother with an EGD. You're going to go straight to medical management. Now, if they have persistent symptoms despite medical management, or if there's a questionable diagnosis, if you put them on 8 weeks of proton pump inhibitors and it hasn't helped, or their symptoms are kind of all over the place, you can do a 24-hour pH test and manometry. Okay, so this is an algorithm from the Cleveland Clinic. I just want to point out, and I know I get a lot of comments about this, there are conflicting recommendations, and that goes for so many things in medicine. There's never broad, full agreement among every medical society about what to do and when. So this is one algorithm that you can use. There are a number of others. But what I want to relate to you is that on your exam, they are going to be really, really clear. So you could get a 67-year-old guy who's lost weight, who's got heme-positive stools, and he's got reflux. He's got reflux symptoms. That is going to be a completely different situation. This guy full of alarm signs. It's going to be completely different than if you've got a 21-year-old woman coming in saying she's got a little bit of reflux symptoms that wakes her up in the middle of the night, and maybe she's got it a few times a month. Those are two completely different situations. One is full of alarm signs. You need to go for an EGD. The other is not. You go to medical management. So they'll be really clear for you on your exam. So this is just general things you need to know. So obviously, if there are alarm signs, you go straight to EGD. If you've got an otherwise healthy patient, just developed reflux disease, go to medical management. Now, initial treatment is usually medical, so we will do proton pump inhibitors. You can also do H2 inhibitors. Go for one of those. Lifestyle modifications, there's a number of things that you can do. Some are evidence-based, others are not, but the big one is weight loss. Of course, like I said, Obesity puts pressure on the abdomen, and that's definitely going to push contents out. Another good one is to avoid food and water right before bed, because when you lay down, gravity is not your friend anymore. So you want to avoid that. Stay upright. If you can, elevate the head of the bed. That can be helpful as well. If you're really experiencing a lot of nocturnal symptoms. There are certain foods that may be associated with increased GERD symptoms, so you could do that as well. Now, when do we do surgery? So surgery is something that we do when medical therapy fails, or if the patient just cannot tolerate being on medical therapy. They don't want to take pills the rest of their life. We can consider doing surgery. So the obvious instance in which we would do surgery if they continue to have symptoms despite maximal medical treatment. Another instance in which it would be really beneficial to do surgery if they've developed aspiration pneumonia, or if they have asthma and they aspirate a little bit, not getting pneumonia, but they aspirate a little bit and it triggers an asthmatic attack. And then sometimes we consider it in very, very young patients, because otherwise they're going to have this the rest of their life. And as you know, repeated exposure to acid in the distal esophagus raises your risk of esophageal adenocarcinoma. And this is one of the findings that you may see when you do EGD. This is Barrett's esophagus. This is a pre-malignant transformation of the lower esophagus. This is bad, bad, bad. So this is an instance in which we really need to do something to address the reflux disease. Now, the Nissen fundoplication is the most commonly performed surgery for refractory reflux for patients who decide that they want surgery for their reflux disease, and presumably a surgeon agrees. So this is done laparoscopically. So being a laparoscopic procedure, it is much less invasive than it used to be when it was done openly. Now, prior to surgery, there's a number of things that need to be done. You do not need to know that for your exam, but just be aware that we don't just run in and do this. There are a number of things that we want to get. We want to make sure that we're doing an EGD, that we're doing a barium esophagram. We want to rule out things like a hiatal hernia or something like that. And so there's a number of tests that are done, but I highly, highly doubt you'll be tested on that. So it's important to understand how this procedure is done, just the basics. So basically, we go in and we separate the fundus of the stomach from the surrounding structures, and then it is taken and wrapped around the lower esophageal sphincter. And essentially, what you make here is a little belt, and that helps give some integrity to the lower esophagus. Now, as you can imagine, there are a number of things that can go wrong with this. Number one, we may actually perforate the esophagus or the stomach with the instruments, and that can lead to an iatrogenic esophageal perforation, which is something I'm going to be talking about in my talk on esophageal disruptions. Another thing that can happen is if we go too tight, you'll have sort of the opposite symptoms, where rather now than having things come up your stomach into the esophagus, you're going to have a hard time getting things down from your esophagus into the stomach. And so that can result in symptoms of fullness, of dysphagia, and certainly of discomfort and pressure after you finish eating. And that's very common in the short term. However, in the long term, that can continue. You can also, with any surgery, you can get adhesions, and that's something that needs to be considered as well. So this is just a recap of everything we talked about. Please keep in mind, you got a patient over 50, patient with alarm signs, go ahead, get the upper endoscopy. If you've got a young, healthy patient with very obvious GERD, just go straight to medical treatment, provided they have no alarm signs. If you've got a patient with persistent symptoms despite treatment, I doubt you'll be asked about this, but if you do an upper endoscopy, comes back normal. The next thing you want to definitely do is a 24-hour pH test and manometry. That is something that you could go straight to, but the recommendations are conflicting.